Morning, hi friends. So after a short break, I am back with my ECG classes here. Since I had completed most of the ECG training classes in my last 18 sessions, hereafter I thought I will be conducting some ECG quiz at regular intervals. I propose to discuss 3 to 5 ECGs per session in these classes. The ECGs will be shown to you for a period of about 2 or 2.5 minutes at the outset when you will be asked to interpret the ECG methodically. You are requested to arm yourself with a pen and a paper and write down your diagnosis. Following this, in the next slide, I will be discussing this ECG in detail along with a few relevant clinical points wherever it is indicated. Of course, I will be discussing the diagnosis also. It would be nice if you could revise the previous sessions of the ECG classes before you take the quiz so that you are up to date with your knowledge. So also, I would like to advise you to proceed very methodically in analyzing these ECGs. Both the 12-lead ECGs and the arrhythmia should be properly analyzed according to the steps which I have enunciated in my preliminary classes. So folks, let us jump to the quiz. So this is the first in the series of quiz. Today I propose to show you 3 ECGs only from my collection of more than 40 years. These ECGs were collected when I was doing my internship, my residency, and later when I was a consultant and a teacher at the medical schools. I request your indulgence here as some of the ECGs are very old and may be a bit faded or frayed, but I think it will serve the purpose of our discussion. Also, some of my esteemed colleagues from the hospital from where I worked before and just retired have also been sharing their ECGs with me regularly. I will be including them also in my discussion. I hope you have armed yourself with a pen and a paper to jot down the points. You may assess yourself and see where you stand in the interpretation of the ECGs. This is a self-assessment. I am not going to ask any questions in this session. And by the way, see that ECG is methodically interpreted. Also, you should write down your points so that when I discuss it in the subsequent the subsequent slide, it should be easy for you to understand. So friends, this is an ECG of a 70-year-old man. The clinical symptoms of this patient are not elaborated in detail here, except that he came to the hospital with a mild chest pain and giddiness. Only the limb leads are shown. The chest leads have not been shown because it is enough for you to make a diagnosis in this patient. Now I have 3 questions of you. 1. What is the cardiac diagnosis in this patient? 2. What other problem does he have? Why is this ECG having a wavy baseline? The baseline is not at all in a straight line. Third, what other conditions may cause this type of erratic or uneven recording in the ECG? I am giving you 3 minutes, so please get going for the interpretation. I'll be waiting. So folks, I hope you have interpreted the ECG. We'll go on to the next slide for the discussion of this ECG. So I hope that all of you have written down your diagnosis in a piece of paper. You can compare it when I discuss this. Now before discussing this ECG, let me show you the normal connections of the leads which I have shown here. Look at the diagram on the right. Now here, lead 1 connects the right arm to the left arm. Lead 2 connects right arm to the left foot. And lead 3 connects the left arm to the left foot. So the right arm is common for the leads 1, 2 and AVR, isn't it? The right arm, this one, is common for the leads 1, 2 and of course AVR, which is connected to the right arm or represents the right shoulder here. Now look at this ECG. The vibrations which you see are seen in lead 1, 2 and AVR. That is, they are in those leads which are connected to the right arm. The leads connected to the left arm and the left foot do not show the vibrations. Okay. So this indicates that the patient has some problem with his right arm or with the connection to the right arm. It could be a loose connection. But here, this patient had a tremor of the right arm, but not of the left arm, right? That is one point. The second point is, you see there is a Q wave. If you look carefully, lead 2 and AVF, these two show Q waves there and the ST is also elevated. Lead 2 also it would have been there, but it is obscured by this vibration which you are getting in the ECG. So the question is that this is due to a acute inferior wall myocardial infarction. So this patient has two problems. One is an acute inferior wall myocardial infarction and the second is a tremor of the right arm. Now the tremor of the right arm was due to, so these are the findings you can see which I have elaborated, and the diagnosis here was a right hemi-Parkinsonism. He had a hemi-Parkinsonism of the right side of the body, that is his right leg and right arm were having tremors or Parkinson tremors. And of course he had an inferior wall infarction. That is what brought him to the hospital because he had a chest pain at that time when he came to the hospital. Now the other question which I asked you is, what are the other causes which can produce vibration in the baseline of the ECG? Right? Any tremor. It can be, here it was Parkinsonism, it can be senile tremor or tremor due to any reason. Or it can be shivering due to cold, just as you get in hypothermia. If the patient is shivering, but when the patient is shivering, usually he doesn't shiver on one half of the body, the whole body will be shivering. So all the leads will show, all these leads will show vibrations in the baseline. The another reason, electrical interference. If your electrical connections in the room or if your patient's connections are touching the wall or so, I think we have discussed it in our preliminary classes, isn't it? Electrical interference. That can produce vibrations. That will have the vibrations of 50 cycles per second according to the electricity supply in our country. So that will be a fine vibration. That also can produce this. Or if there is a loose connection of the lead to any of the limbs, that also may produce variable vibration. So these are the causes which you have to consider when you discuss such a patient. So this is your second case, friends. Now this is a straightforward case. Now I would ask you the questions. What is the full ECG diagnosis in this patient? This is a 12-lead ECG. So what is the full diagnosis? Second, what is the QRS axis in this patient? And the third question is a clinical. What is the auscultatory phenomenon you may find in this patient? Okay, I am giving you about 2.5–3 minutes for discussion. Okay, interpret this and come with an answer. So friends, we will go on to the answer in this quiz. We'll go on to the next slide. So what are the findings here? I hope you have written it down. 1. You can see prominent Q waves in leads V1, V2, V3, V4 and V5. Of course, V6 is not clear in this slide because my photo is obscure in it. And that indicates what? It indicates an anterior wall myocardial infarction. Now the Q waves in V1, V2 and V3 are followed by tall R waves, isn't it? This is not seen in a common garden variety of anterior wall myocardial infarction. There you expect a QS pattern with an ST elevation and T inversion, isn't it? You get a QS pattern. I'll show it to you. Hence, the presence of tall R waves denotes what? An additional right bundle branch block. Now I asked you what is the QRS axis in this patient. Note that the lead with equiphasic deflection in this limb leads would be here, isn't it? AVF gives you the equiphasic deflection. And the AVF means it is exactly pointing downwards, that is 90 degrees, its axis. And lead 1 and AVL, if you look carefully here, they are positive. So the axis is towards the left. And when AVF is biphasic, the axis will be 0 degrees, isn't it? Now here, what does this tell you? The patient has a right bundle branch block. We have discussed that when there is a right bundle branch block, the axis is usually normal or the axis may be slightly to the right. Whereas what happened here, the axis is to the left actually, even though it is not classically a left axis of -30 or -45. The axis is to the left means it is 0 degrees, where you expected a right bundle branch block axis of normal or to the right. This indicates an additional left axis for this patient with a right bundle branch block. So it would suggest a right bundle branch block with what? A left anterior fascicular block, or it is a bifascicular block, isn't it? It's not a pure RBB, there is a bifascicular. Now third question which I asked you is what is the auscultatory phenomenon here? So before that, I would like to just give you the diagnosis here. So Q waves seen in leads V1, V2, V3, V4, V5. Tall R waves in lead V1 and V2. ST elevation with T inversions in leads V1 to V6. It is there. Diagnosis will be anterior myocardial infarction, right bundle branch block and left anterior fascicular block. Now this is the pattern, the QS pattern with ST elevation and T inversion, which should have been here if there were no right bundle branch block. So if you see a QR pattern, think of a right bundle branch block with infarction, and QS pattern, there is an anterior wall myocardial infarction without a right bundle branch block. Now my last question was, what is the auscultatory phenomenon which you expect in this patient? I'm sure all of you are very good in your clinical science and you would have answered this. The second heart sound in this patient would have shown a wide split, isn't it? A wide split which slightly varies with respiration. This would be due to the right bundle branch block of the patient. Okay, so I'm sure that all of you would have got this ECG also right. With that, we'll go to the third ECG or the last ECG. So this is a rhythm strip with the lead not specified here. So it could be from the bedside monitor. Obviously, this is an arrhythmia because you see only a single strip of rhythm. What is your diagnosis of this arrhythmia? Now follow the few principles which I have told you how to analyze an arrhythmia, and this we have discussed in detail in the sections on arrhythmia, the initial sections on arrhythmia, and analyze this ECG methodically to arrive at the diagnosis. Now my second question here is, what would you do for this patient if this was a case of acute myocardial infarction with this? So get on friends, and I'll give you about 2 to 3 minutes for discussion. So friends, I think we shall go on to the discussion of this. I'm sure that all of you would have written your diagnosis here. So let us look at the P waves first. Now we have told that this is an obvious arrhythmia. Now where are the P waves? Now look at this. I have marked the P waves with red arrows. One P wave is here. Another P wave is here between the T wave and the QRS. The third P wave, of course, very obvious, just in front of the QRS. And then this fourth P wave is falling on the T wave. That is why this T is taller than all the other T waves, right? So it is a P on T. Now here you can see the P wave falling at the beginning of the QRS, and here you find the Q wave after the T wave. And of course it goes on like that. You can find out the others by yourself. So the P waves are coming at a rate of 100 per minute. Now we'll go on to the QRS complexes, right? The QRS complexes, they are narrow. So if they are narrow, they are coming from where? They are coming from above the bifurcation of the bundle of His. Are they regular or irregular? They are coming at regular intervals of how much? This is, if you calculate this, it would be 75 per minute. So the QRS complexes are narrow, coming at a rate of 75 per minute and are regular. Right? Now, we have already discussed where they are arising from. Then two questions I always ask when this happens is, are all the P waves followed by QRS complexes? See, there is a P wave here and the QRS is late. This P wave is not followed by a QRS. This, of course, followed by a QRS, which may be accidental. This P wave on the T wave is not followed by a QRS. This, of course, it is falling almost inside the QRS. So the P is not always followed by a QRS. Now, are all QRS complexes preceded by a P wave? That's the next question. See that this is not preceded by P wave. This is far away. This is not preceded by a P wave. And you have this one, this QRS is not preceded by a P wave. So all QRS complexes are not preceded by P waves. So we say that the P and QRS are dissociated, or as I use the word, they are divorced from each other. And the P waves are not causing the QRS complexes. This is called AV dissociation or atrioventricular dissociation. Now the question arises, where is this QRS coming from? Being narrow, we said it is coming from above the bundle of His. So it has to be from the junction or the AV node. We have already said that it is not from the sinus because we said the P's are not causing the QRS. So it is not from the sinus. So the next choice will be from the junction or the AV node. What is the normal rate of the junction or a junctional rhythm rate? It is 40 to 60 per minute. But here what happened? It is running at a rate of 75 per minute. So what do you call it? When the junction beats at a faster rate, less than 100 but more than 60, you call it an accelerated junctional rhythm. So the clinical, this you have seen. So these are the things which you have to see. One, P waves are dissociated from QRS. P waves are coming at a faster rate. QRS is coming at a rate of 75 per minute, which is due to the accelerated junctional rhythm. So the regular narrow QRS complex, P waves regular, dissociation of P and QRS, and the diagnosis here is a complete heart block with an accelerated junctional rhythm, right? So this is the full diagnosis in this patient. I'm sure that all of you would have got this right if you have followed my previous sessions diligently. So friends, we have come to the end of the discussion today. One point I had forgotten to discuss in the last slide was that I had asked a question, what will you do for the patient here if the patient had an acute myocardial infarction? If the patient had an acute myocardial infarction, if he is hemodynamically stable with a heart rate of 75 per minute, you just observe the patient monitoring. You don't have to actively do anything for the arrhythmia at this point. If there is a deterioration also, then you will have to treat the patient. But of course, you will have to take the appropriate measures for the management of the myocardial infarction. That's a different point. But as far as the arrhythmia is concerned, with a rate of 75 per minute and with a good hemodynamic stability, don't do anything for the arrhythmia. Just monitor and carefully watch the patient. So friends, today we have finished 3 ECGs for this session, and more such ECGs and discussions I would like to give you in the subsequent days. Please be ready for this. I would advise you strictly to revise all these previous sessions once again so that you are familiar with the interpretations and can do it easily and efficiently. Meanwhile, kindly share this with your friends and colleagues and subscribe to my ECG classes in the YouTube. Give me your suggestions and comments if you want any specific areas of ECGs included in these sessions. Now you can give the comments in the YouTube itself, or you can WhatsApp the messages to me, or you can even email me your questions or suggestions or so. If you think that I am too fast in my discussion, or if I am not clear enough in my interpretation, whatever, you can always be frank with your discussion and your opinions. So long friends, we'll meet you in the next session of the ECG quiz. Namaskar.